I was the only physician in the entire district of over 350,000 people. Isolation is one of the things that crushes physicians in those situations.
Welcome to Healthcare Perspectives, a podcast by Siemens Healthineers about medical breakthroughs with the power to improve lives everywhere. You just heard Dr. Geoff Ibbotson, surgeon and executive director of the Global Surgery Foundation. In this episode, host Hagen Weissapfel is joined by our guests to explore access to care for underserved communities through education and training.
Hi, I am Hagen Weissapfel. Access to quality healthcare remains out of reach for millions of people around the world. Individuals in low and middle income countries, as well as those in rural or underserved areas in wealthier nations, struggle to access even the most basic services. Whether due to distance, infrastructure, or economics, many go without timely diagnosis, treatment, and the opportunity to live longer, healthier lives. One of the biggest drivers of this issue is a global shortage of trained healthcare workers, and this problem has only grown, fueled by workforce migration, gaps in education, and limited local training opportunities. Today, we look at how we can close these gaps through education and technological innovation. From training the next generation of providers to expanding digital learning platforms and forming trusted local partnerships, we explore how sustainable solutions can unlock access to care in underserved communities. I'm joined by Melissa Culp, Executive Vice President of Member Engagement at the American Society of Radiologic Technologists, or ASRT. She brings decades of experience in global health and medical imaging education. Also, Dr. Geoff Ibbotson, surgeon and executive director of the Global Surgery Foundation. Over the past 25 years, he's worked with the front lines in conflict zones and low-resource settings, and now leads programs that strengthen surgical systems through education and training. Before seeking the solutions, it's important to understand just how vast the access gap really is. Geoff Ibbotson has seen this firsthand across the globe, from the mountains of Nepal to the conflict zones of Sudan.
I started my career back more than 25 years ago, working as a frontline surgeon in some of the most remote areas of the world, from the jungles of Borneo and Papua New Guinea to the Himalayas of Nepal to the Sudan crisis in North Kenya. It was out of those personal experiences of seeing people suffer that really drove me to try to make a difference and try to meet the needs of those who are in those situations. Of my professional career, I would say I've spent about 60 to 70% of it on the front lines in low-resource settings doing this work. And about 10 years ago, started moving out of the operating room into the boardrooms and doing leadership development and program development. And in 2019, we formed the Global Surgery Foundation as a platform to help move forward the agenda of global surgery worldwide. I'll share a story from many years ago when I was working in the country of Nepal. I was in a district hospital up just south of Mount Everest. It was during the Civil War. I was the only physician in the entire district of over 350,000 people, and obviously the only surgeon. We had no electricity because the rebels had knocked out the power grid, and I had no communication other than a satellite phone, which I would use maybe once a week. I used that illustration to basically tell the story of the main challenge of many people trying to do their best in remote areas. It's isolation. Isolation is one of the things that crushes physicians in those situations because they don't have that connection to their colleagues. If I have a difficult case, I have no way to bounce these ideas off of other people. Since that time, now to today, there is connectivity. Even in some of the most remote areas, you can download stuff and then go offline and use that. So digital communication, digital technologies to break down that isolation is an amazing game changer for where the need is sometimes the greatest in these remote areas.
The sense of isolation isn't just geographic, it's systemic. And it's something Melissa Culp has also seen in her global outreach work. She records a moment in Malawi that brought the access gap into sharp relief.
I reflect on a particular story when I was in Malawi in my prior outreach work. So Malawi is a nation in southeastern Africa, and it's a beautiful place and really had great partners there, great collaboration, really wonderful people that we worked with. But I remember being there at one of the central hospitals, which is what they would call a tertiary care hospital. So at a central hospital, I was standing outside with the radiographer there. So she's called radiographer in that setting. And the pediatric surgeon came up. We're outside, and he holds up the CT film. They had printed the CT, which normally if I think about a CT, I'm looking at it on a computer screen and scrolling through it. But this is printed, and there's lots of little boxes with the different slices of the CT printed out. And he's looking at it and talking with the radiographer about this patient who's a little boy who had a rhabdomyosarcoma. It's a tumor that goes into your muscles. It was in his femur and had grown into his pelvis and had really grown invasively. On the imaging, he's able to see it. And so when the surgeon is talking about this patient and like the continuum of care and like what next, the next step is doing surgery to remove some of the tumor as palliative care because there's no treatment for that there. And what was striking is my older son was the same age as this kid at the time. And if I think about where I live, I have 2 tertiary care facilities within 10 miles either way. So if my kid had this rhabdomyosarcoma here, there would be like all the things available. So there's truly like a lack of access to care, not for fault of the healthcare professionals, because they want to do everything they can, but just an uneven distribution of resources globally.
This is just one experience that shaped Melissa Culp's perspective on global healthcare during her career that led her to the American Society of Radiologic Technologists.
I'm a registered technologist in radiography and magnetic resonance imaging, and we're the healthcare professionals who acquire imaging in the medical environment. In my background, I've worked clinically in MRI at a tertiary care facility. I was a faculty member at the University of North Carolina at Chapel Hill for 10 years and served there as the director of global radiology. Concurrently, I was very involved with a nonprofit called RadAid International, which focuses on increasing access to radiology and radiation oncology services in global health. And I served as the vice president and chief operating officer of RadAid for 6 years. More recently, I joined the American Society of Radiologic Technologists as the executive vice president of member engagement. The American Society of Radiologic Technologists is the world's oldest and largest association for medical imaging and radiation therapy professionals, with more than 155,000 members. And our mission is to advance and elevate the medical imaging and radiation therapy profession and to enhance the quality and safety of patient care.
To make real change, interventions are needed at all levels, in policy, practice, and patient experience. But for Melissa Culp, it's education that has the power to be one of the most sustainable forms of impact.
In global public health, when we do intervention work, there's 3 places where you do intervention. So upstream would be policy or like systems level changes. Midstream is an educational intervention. And then downstream is acknowledging the fact that a disparity already exists and really meeting patients or people where they are in the context of the disparity. And when you think about global health, you really have to do all 3. And education is really one of the most sustainable ways to make change within global health and to strive towards health equity, because you're really empowering the local professional based on the system they live in, based on what their needs are. So that knowledge lives in the country and impacts all the patients there in that country. So it's really a very sustainable way to do intervention in global health.
Through ASRT's foundation and its long-lasting partnership, Melissa Culp has seen the potential of educational outreach to bring imaging and radiation therapy services to communities that need them the most.
ASRT Foundation is our philanthropic arm, and through partnerships with corporate partners through the foundation, ASRT has sent more than 200 global outreach fellows into underserved areas to provide education to increase access to medical imaging and radiation therapy. In our current expanded partnership with Siemens Healthineers, ASRT is able to bring our gold standard educational content into lower middle income areas of the world as defined by the World Bank to really increase access to medical imaging and radiation therapy services globally. And within this partnership, we're co-creating content that's really needed within these countries. And our first site that we're working in is in the nation of Ukraine. And what I love most about it is the emphasis on the in-country partners, that the Ministry of Health is involved and that local Ukrainian healthcare professionals and educators are really leading the way on what's needed in their own nation through the partnership.
Geoff Ibbotson echoes that emphasis on sustainability. For him, empowering local professionals is key, and digital learning platforms like Search Hub has become critical tools in that mission.
I keep referring back to the Surge Hub, which is our learning platform. Just a little bit about that, which I think is really quite interesting, and I would encourage everyone to go visit surgehub.org. It's a learning platform for surgical care systems. We now have over 20,000 users in over 200 countries and territories around the world. This allows the physicians to look up lots of different courses to walk you through different procedures. And the feedback we're getting from our users is that it's really been a game changer. Additional to that, especially with surgery, there'll always be the need for face-to-face hands-on training. And we've done this for decades, this kind of training. But in the old days, what I would do if I was training something, a team on trauma, I would give them a slideshow at the beginning of our face-to-face training session, 2-3 day training session, and then have to do the didactic portion face-to-face. Now that can all be done pre-course on the Surge Hub digitally, and they get a certificate saying, yes, we've completed all this. And when you do go to a specific country to do the hands-on face-to-face training, you can dive right in. So our instructors who are now using the Surge Hub in this way are saying, again, this is a game changer and making a huge difference moving forward.
The ability to scale high-quality education while keeping it rooted in local systems and needs is what makes these training efforts so powerful. And it begins with visibility and awareness.
What we really need to do and what ASRT is focusing on is increasing awareness of the profession. We have currently a public awareness campaign where we're really teaching the public and targeting the public to understand that medical imaging and radiation therapy professionals are part of the healthcare environment. So if you think like when I was a kid in high school and I watched TV, it seemed like doctors and nurses did all the things in healthcare. And those are very wonderful professions, like doctors and nurses. We need those professions. They need more support. We're all an interdisciplinary team. But for me as a kid looking at TV, that was all I saw. So what ASRT is doing is really taking steps to show the public, hey, there are other roles in healthcare, like medical imaging professionals are there, radiation therapists and therapy professionals are there, and kind of elevating the awareness of the profession so that more younger students know, like when they're a high school student like I was, that, oh, this is a choice. I can do lots of things in healthcare. So that raising awareness, and really ASRT is doing a lot of outreach to middle school, high school students and then to like school counselors and that area to really show that this is a path that can be done. And that's a long-term effort that we have to continue and sustain.
Technology can be a powerful tool for learning, but only when it's rooted in trust and local leadership. For Melissa Culp, her belief is that any educational platform must start with the people it's meant to serve.
When we think about global health or disparities and striving for health equity, there's really 3 levels of intervention that have to happen, like holistically. And it doesn't mean every organization has to do all 3. It just means all 3 need to be there in some way. So there's upstream, which is policy work. So what at a policy level would support patient care? That can be like institutional policy, it can be for the government's policy, or it can be like global policy. So at the policy level, there's midstream interventions, which are education. So educating the workforce, making sure that the educated workforce has the resources that they need. And then downstream interventions are really acknowledging that people already exist in the system of which there are health disparities. So it's making sure that people have what they need while the upstream and midstream interventions happen. So you have to address all 3. All organizations don't have to do all 3, but all 3 need to be there. And truly collaboration through like nonprofits or NGOs, non-governmental organizations, with government and with corporate partners. So really leveraging all the players that are there. And I think most importantly, listening to in-country partners or local stakeholders, because anything done has to be led by the local partners. Therefore, it would be appropriate in the culture and the customs and the laws of that place. So I really think cell phones are more handy than you would think, because anyone, anywhere, like in my global health experience, has a cell phone. But then also tools like computers with Zoom or Teams or different virtual ways that we would meet with each other. These things can be a nice adjunct within global partnerships. So one example from this, we had that existing partnership in Malawi, and we were focusing on ultrasound in that area and ultrasound education. And then the pandemic came. So travel was limited for a little while, but the people with whom I was working in Malawi and the partners here created a hybrid ultrasound curriculum where content was delivered virtually over a virtual video platform. And then in country, the local sonographers would do hands-on work with their kind of trainees or their medical imaging professional learner cohort. So it was a mix of content delivery and then in-person hands-on that really worked well and allowed the partnership to continue and allowed educational goals to continue to be met, even when travel wasn't possible.
Sharing a similar perspective, Geoff Ibbotson says the same in surgery. Technology must complement and not replace real human relationships. That's why the Global Surgery Foundation invests in long-term mentorship.
You put on a pair of glasses, your mentor put on a pair of glasses, and he's in the operating room with you. And at that point, he can walk his colleague through a complicated case. And that's the hub and spoke connectivity. Move the arm that way a little bit, push that way, do this, do that, and the case is done. You have your mentor looking over your shoulder as the case is being done. And digital technologies now allow that, whereas 20 years ago, that wasn't even thinkable. In the traditional methods, we'll probably never catch up in the number of healthcare workers that we need to train. And so we need to look at other ways. We need to look at task shifting, task sharing, and getting the needed information out to the healthcare providers that is giving them that support, breaking down the isolation. So for us, our main thrust is with the Surge Hub and making that available around the world. And the fact that it's in almost every country worldwide is a testimony to the need. We've actually been quite surprised at the uptake, and I believe that it'll only continue to grow quickly as we continue to promote the platform.
And when it comes to building new training content, Melissa Culp notes that it's the community that leads.
Trust and relationships are key for the success of any partnership, including any technological intervention or integration. And Siemens Healthineers has carefully fostered those relationships with in-country colleagues.
While tools and training matter, true equity requires system-level change, because even small gaps in technology access can lead to devastating consequences.
At the end of the day, when I'm finished, I go and review the x-rays, and I see this x-ray, and oops, it's not aligned well. I have to take the patient back. What a waste of time and energy. So then I have to book the patient for the next day. It takes up another slot in the operating room. The patient has to undergo anesthesia a second time. There's risks of complications with the anesthesia, with bleeding, infection, all the rest of it. Whereas if I had had that C-arm in my operating room, it would have been 10 seconds and I would have known, I would have fixed it, we'd be done, patient done. So for the 96% of hospitals that do not have a C-arm, the bad scenario is what they have to deal with. Now, how can that be good for the patient? At the end of the day, my priority is the same as the medtech company selling those C-arms, because that's good business for them, but it's good care for the patient. I'll tell a little story, in terms of medtech. I looked into strategies for trauma care. Trauma is one of my passions, and particularly in global health. And I did some literature review and found that only 4%, just 4% of district hospitals in sub-Saharan Africa have a C-arm in the operating room. Now, a C-arm is an X-ray machine that allows me as a surgeon to take an X-ray immediately of a broken bone that I've tried to fix in the operating room setting. To think that I would have to do all these operations without immediate X-ray, it blew my mind. Only 4% in all of sub-Saharan Africa. So let me take a step back and give you a scenario of what would happen if I don't have a C-arm. I fix the bone in the operation, I put a pin in or do whatever, plates and screws, and then I wake the patient up. The patient recovers in the recovery room, and later that afternoon goes down to the X-ray department, gets an X-ray. The thought of not having a C-arm in the operating room is actually scary in a way. Why don't we have C-arms in these? And there were three main reasons. One was cost. The other was, we don't know how to use them safely because it is radiation and there are risks to that. And we don't know how to use them in terms of the clinical aspect. That's where we said, let's do a course and put it together with all of our partners to give this information so that ceases to be a reason.
But training is only part of the picture. Systems must be built around the needs of the community. And that starts with asking the right questions.
We're just finishing up a program in Rwanda in the relatively remote areas, and we're looking at breast cancer. And we realized that the surgeons there were seeing a lot of breast cancer in very late stage. Why? Why aren't the women coming in? The hospital is there. It's not that far to get to the hospital, but the women were coming in relatively late stage, which means the outcomes are quite poor. And so the way we get to that point of identifying the pain points is taking a look at the community and asking those questions to the patients, to the healthcare providers, to the community health workers in the villages. And we just completed a 2-year pilot project in value-based healthcare with breast cancer in Rwanda, now getting that data back. And one of the shocking things was surveying the patients. So the patients, they don't want to come in because if they come in, they think, I'm going to have this big, horrible operation and then I'm going to die. So why would I bother coming in? So that's a misperception. On the other side, we talk to the physicians and we say, why is this happening? And they say, we don't have radiation to provide radiation to the patients. So everyone gets a total mastectomy. If you had radiation as an adjuvant treatment, then you can have a relatively simple lumpectomy, and that's better for the patients in many cases. And then the perception of the patients change. So hopefully we'll be able to get them coming in earlier when perception and stigma starts decreasing, and appropriate treatment with chemotherapy and radiation as a full package, as recommended in the WHO guidelines. That's a full package, but you can see that the system isn't complete, and that dictates or influences the decision-making of the patients. So you can see it's relatively complex, but you have to dive into it with the local stakeholders and ask those questions, and particularly ask the questions to the patients themselves. And that's what we're really excited to see, some of the data that's coming out.
Thanks to real-world data and studies like this, Geoff Ibbotson and his team can identify the right levers for change.
I say that to be quite optimistic. Even with the doom and gloom of all the funding cuts, I think we're at a tremendous opportunity to make a difference with relatively small catalytic funding for large impact, local sustainability, local scalability. The challenges are that mindsets are always difficult to change. And for far too long, the perception in global health is that surgical care is reserved as an expensive intervention for the rich only, which is absolutely false. And if we look at the data, we can see that the return on investment for surgical care systems is comparable to vaccinations and primary healthcare interventions if done properly. One of the things that most people don't realize that in Europe or North America, any high-income country, breast cancer survival rates would be around 80%. And in low-resource settings, like in sub-Saharan Africa, is 20%. So where's the equity in that? No equity there. So how do we work together as funders, facilitators, ministries of health, medtech companies to close that gap in equity? And that's the key question.
Both Geoff Ibbotson and Melissa Culp emphasize that we already have what we need to move forward. What's required now is alignment, investment, and action.
People are finally starting to see the opportunity to make a difference. With our maternal health, we're seeing a 30% reduction in maternal mortality, 40% reduction in neonatal mortality, and as I said, 50% reduction in complications with very little investment.
Throughout this conversation, we've heard what it takes to build lasting impact: trust, training, and collaboration at every level of the system. From the operating rooms of Nepal to the radiology units of Malawi to virtual connected learning platforms used across 200 countries, Melissa and Geoff have shown us what access really looks like when it's rooted in partnership and sustainability. And sometimes the biggest breakthroughs happens with the simplest questions. How do we get to the next level? By identifying the pain points and building solutions with the community and their existing resources, whether it's task sharing in surgery, awareness campaigns for imaging careers, or investing in digital mentorship, these leaders are shifting the future of healthcare delivery. And they are proven that even small, focused investment can lead to measurable impact.
I think the world, in terms of financing, requires higher impact for the investment being made. And that's going to be the major shift. I believe that is something that we're already doing. We're showing with very minimal investment some significant impact moving forward.
And as powerful as technology is, it's still the people at the heart of every system. From underserved rural districts to hospitals in conflict zones and supply shortages, the people delivering care are already doing the hard work. Our job is to ensure they have the tools, knowledge, and systems to support them.
The relationship piece is the foundation. So if you don't have a relationship and the trust isn't there, then any sort of like digital add-on or digital communication tool may not be landing correctly, or it may not really be helpful.
You have been listening to Healthcare Perspectives, a podcast by Siemens Healthineers. We pioneer breakthroughs in healthcare for everyone, everywhere, sustainably. Subscribe to us and always get the latest episode in your podcast feed. Or visit Siemens-Healthineers.com/podcast for more. The opinions expressed by the guests and contributors in this podcast are their own and do not necessarily reflect the views of Siemens Healthineers. The statements by Siemens Healthineers customers and partners in this podcast are based on results that were achieved in their unique settings. Because there is no typical hospital or laboratory and many variables exist, e.g., hospital size, samples mix, case mix, level of IT and/or automation adoption. There can be no guarantee that other customers will achieve the same results. This podcast describes possible future ideas and concepts. It is not intended to describe specific performance and/or safety characteristics of currently planned or future products. Future realization and availability cannot be guaranteed.